Yeah, thank you for your presentation. I really appreciate it. I do want to point out a couple things.
Yeah.
Number one, the legacy patients, which I don't particularly enjoy that term.
Yeah.
We did this to them. So we can never forget that these prescribing habits, we did.
Yeah.
And we've created this problem. And the second part about this, though, is absolutely we need to, I'm a firm believer in making things as patient-centered as we can. How do we implement that on a system-wide basis when we know that there are known associated harm with these medications? Now, what has been kind of absent in a lot of this discussion is what does chronic opioid therapy do to the brain? And when we start looking at that neurophysiology, what we see overlap with suicidality, we see overlap with other mental health disorders, we have overlap with worsening pain as well. So this is, I just want to point out that this is a huge issue. Yeah. That these opioids are all kind of tied into there.
Yeah, absolutely. And indisputably, lower doses are safer. But when we talk about mandating a taper and really going forward without having careful and thoughtful methods, by imposing that, we risk the gravest harm by destabilizing individuals, both medically and psychologically, and that is the inflection point that must be addressed.
And, I absolutely 100% agree with that, and that was one of the reasons the top recommendation that we had in this task force, for which had gotten no press at all, was pain education. Yeah. Because there is rampant misinformation, there's rampant misunderstanding, there's rampant misconceptions when it comes to pain and drugs and all these other therapies, and that I think is one of the intentions that we are hoping to address in the future.
Yeah.
Because when you start looking at this stuff and you realize that where these drugs work in the brain, and every drug that we take works on a natural receptor, and we start realizing that those endogenous opioid systems are working on things like not only pain, but stress management, reward and motivation systems that are affecting other organ systems in their body. If we can incorporate that into good pain education, where you get providers to understand what this works with their patients, when you have people in the audience understanding what these drugs are doing long-term view, lo and behold, then everybody's in agreement and on a path that we can move towards forward. I mean, it's very, very difficult to do on a public policy standpoint when we're in these little task force things and you have to put on one page of paper. But I do appreciate that, and I absolutely, how can we implement this? I'm going to speak briefly to the audience members here. If you guys understood as well about how all this stuff worked together, I guarantee how many people love being on opioids? How many people enjoy being on these drugs? How many people
have a choice?
That's it, right?
Amen.
Well, I'm going to say here, we perceive we don't have a choice because we don't understand the issues enough. So I just want to...
That may be your point of view. That's your point of view.
You are making a derogatory, negative statement.
Thank you.
These people who are living with chronic pain and who are doing everything in their power to try and maintain their quality of life, stay alive, and deal with external stressors, including the possibility...
There are doctors and nurses in this audience.
You are the problem.
And I apologize. I apologize.
It's insulting.
That is not what my perception is.
Insulting.
What I am trying to say here is there is a whole bunch of misconceptions when it comes to pain and pain science. I'm speaking.
There are.
And I'm telling you from somebody who's a fellowship-trained pain specialist.
I appreciate that.
Okay.
There are a lot of misconceptions, including on the part of the ladies and gentlemen of this committee and prescribers in general. However, when we decide to come together and stop accusing each other and stop associating addicts, people who are dealing with substance abuse issues, with patients who are legitimately trying to
Yes.
and management of their pain, then we can move together. Yes, nobody wants to be on opiates. Yes, we are aware of the contraindications. And yes, we are trying to find a way to live our lives pain-free.
And I appreciate that, and I do not mean to insult you. And I certainly don't want to derail. I don't want to derail the conversation here because.
Thank you. Apology accepted.
I'm going to please ask, we have public testimony in about 10 minutes. There's a few other items that I need to make sure that the task force has some input on. Thank you so much, Dr. Darnall. I really appreciate that you coming out here and